Let's further look into the abdominal assessment and the concept of elimination. So this slide is just simply a recap from your A&P courses that you took as your prereqs. So what are those main functions of the digestive system? So essentially it's to digest that food that we intake, absorb the nutrients from the food, and then remove any waste. So these are just some terms that you guys should know in regards to the digestive system. Before we start talking about the abdominal assessment, it is really important that you are aware of these key organs that are involved in digestion and elimination and what we will be testing and looking for during an abdominal assessment. So making sure that you are aware of what side of the body and the location, what quadrant, like the liver, the spleen, the stomach, pancreas, gallbladder, your colon, your small intestines, making sure you do know all of these along with your kidneys. And that is that posterior view on the bottom right-hand corner. Here's two more visual aids. The first image is going to show you how you will break up the abdomen into the 4 quadrants. So when we are talking about doing different assessments regarding the quote unquote quadrants, this is the image that you'll reflect to. So you have your right lower quadrant, your right upper quadrant, your left upper quadrant, and your left lower quadrant. And then the image on the right, that is where we can break it down into regions. So it's a little bit more specific. And so knowing in those regions where certain organs are. And so if somebody comes in with, say, epigastric pain or region in that or pain in that epigastric region, we know up in that region, your stomach sits there, the liver, pancreas, the duodenum, spleen, and the adrenal glands. So we are not concerned per se initially of maybe female reproductive organs. We're not thinking that they may have like an ovarian cyst. If they came down with a hypogastric region, pain in that area, that is when we would be concerned of those female reproductive organ issues, along with like the bladder and the sigmoid colon. So it is important that you are aware of where the organs are located within the abdomen and the quadrant slash region. So then we jump into what is a solid versus a hollow viscera. So a solid viscera, that simply means that the organ itself maintains a consistent shape because essentially it's a solid structure. So typically it's going to always maintain a form, the same form regardless of what the contents are. They are typically highly vascular, and oftentimes they do involve the endocrine and metabolic functions. If you were to have pain with a solid viscera organ, the pain's typically going to be like a dull, achy, sometimes poorly localized if it's injured or inflamed. So some examples of solid viscera, that's going to be your liver, your pancreas, your spleen, adrenal glands, your kidneys, and your ovaries, if you have a female patient. Then you have your hollow viscera. So this is an organ that can change shape and size depending on the content. So depending on what is in it. So typically they're going to be like a quote unquote tube or a sac organ. Think of these organs, the characteristics, they're going to expand and contract. Contents can move through them, so whether that's air, fluid, food, waste, whatever it is. If you were to have like a blockage in a hollow organ, then that could produce like an acute, severe, crampy pain. Now, for some reason, an organ become perforated, that's a hollow viscera. This would be a sudden severe pain due to any leakage that goes into the peritoneum. So examples of some hollow viscera, this can be your stomach, your gallbladder, small intestine, large intestine, colon, the bladder, and the uterus. When non-pregnant, it is a hollow viscera. So next up, we need to be collecting some subjective data. So if somebody comes in, one of the number one presenting complaints is going to be abdominal pain. Abdominal pain is going to occur when one or more of the digestive organs or the surrounding structures become one of these listed characteristics. So it could be inflamed. That typically is going to stimulate the visceral nerves, causing this dull, achy, and sharp pain. So this you can think of appendicitis, cholecystitis, pancreatitis, hepatitis, really anything that ends in the titus, which means inflammation. Then you have infected. So an infection can cause swelling, irritation. It can increase the pressure within tissues, causing pain. So examples of this is gastroenteritis, diverticulitis, peritonitis, things like that are infection can cause those pain. A pressured or compressed, so that is when pressure on the organs or nerves leads to a discomfort or severe pain. So this can happen when there's a mass, a tumor. If a woman is pregnant, pregnancy related pressure that can cause pain and enlarged organs. Then you have like distended. Distended, typically it's gas, fluid, or stool buildup stretching these organs. It's typically going to feel pretty crampy and maybe like a colicky pain. Examples of a distension pain could be from bowel obstruction, constipation, or bloating. Then you have stretched. So the stretching of the organ capsule, the liver, spleen, or hollow organs, they're going to trigger this like visceral pain. So thinking of hematomegaly, that's like liver swelling, splenomegaly, gastric distension. And then you have an obstruction, so this blockage that's going to interrupt a normal flow of contents. That is going to feel very severe, crampy, intermittent-like pain. Examples of an obstruction is a small or large bowel obstruction, a biliary obstruction, maybe kidney stones. And then if that area becomes traumatized, so if there is an injury to an abdominal structure, that's going to cause an acute localized pain. So examples of traumatized, that's if they have like a blunt force trauma, surgical injury, or maybe even like a perforated ulcer. So then we have abdominal pain regarding acute versus gradual. So acute is also known as sudden onset abdominal pain. So this is when pain that it begins abruptly. Often it's going to feel very severe, it's unexpected, and it's rapidly worsening. So this clinically is going to be more associated with an emergent issue, potentially life-threatening conditions. So common causes of these acute pain would be acute pancreatitis, cholecystitis, possibly a perforation, maybe an obstruction, some type of rupture or torsion, an ectopic pregnancy rupture, renal colic or kidney stones. Um, and then we just really need to be aware if somebody does have acute or sudden pain that we look for these like red flag symptoms. So do they have a rigid abdomen? Are they guarding? Are there any signs of shock? What about hematemesis or melena? What about a fever or severe pain? What are they rating this pain? If there's any episodes of syncope or near syncope, those are some red flag things that we definitely need to notify that provider of as soon as possible when it comes to that acute or sudden pain. Then you have a gradual onset abdominal pain. So this is when the pain is developing slowly over hours or days. It may start mild and then progressively gets worse. So this often clinically suggests like an inflammatory or an infectious process. So common causes of like this gradual abdominal pain would be appendicitis. Typically, appendicitis will begin pretty like vaguely and then gradually it intensifies. Think of cholecystitis, diverticulitis, gastroenteritis, peptic ulcer disease, a constipation, UTI, IBS. Those are going to be more gradual pain. The characteristics of these pain, of like a gradual pains, typically can be dull, aching, cramping, or like a pressure like. Again, it worsens with if there is inflammation, if that inflammation progresses, and it may allow that patient to continue their activities of daily living initially. They can kind of live with it, and then gradually they're not able to. And then you have different sources of abdominal pain. So first you have visceral pain. So this arises from our viscera, such as the stomach, intestines, pancreas, liver, gallbladder, and it's caused by a stretching, distension, maybe ischemia or inflammation of the organ. It's typically going to feel pretty dull, crampy, achy, or pressure-like, and typically it's poorly localized. So the patient just may gesture over a general area. There is not like a pinpoint of exactly where this pain is occurring. So this can happen with early appendicitis, if there's a bowel obstruction, or maybe hematomegaly or splenomegaly. And then next you have parietal pain or somatic pain. So this is an irritation of the parietal peritoneum, which is that lining of the abdominal cavity. Typically, it's going to be caused by inflammation, infection, or irritation of the peritoneum. A patient may describe this as sharp, intense, and a pretty localized pain. It will be worse with movement, coughing, or pressure, and then the patient will lie still with their knees drawn up to help kind of reduce that peritoneal stretch. So you may see that. Examples of a peritoneal pain would be maybe your later appendicitis. So when it becomes that right lower quadrant localized pain instead of generalized, peritonitis, perforated ulcer, that's maybe leaking some gastric contents, diverticulitis with localized peritoneal irritation. And then you have referred pain. So this is pain that is felt at a site distant from the affected organ. And this is due to severe or due to shared nerve pathways. So what can cause this? So these visceral afferent nerves converge at the spinal cord level with somatic nerves, creating this like misinterpretation of where the pain's located. So typically the individual will say they have like a well localized but like pain location, but it's distant from where pathologically the pain is occurring. It often is a predictable patterns. And classic examples of referred pain is one, you may have somebody may come in with shoulder pain. That could mean that there is a diaphragmatic irritation, so a gallbladder, liver, or spleen injury. Something's going on there. If someone comes in with back or flank pain, a lot of times we're starting to think, ooh, is something going on with the kidneys? Is there kidney stones? What about pancreatitis? Sometimes individuals may have this right scapular pain, and that can happen with gallbladder inflammation. And then individuals can also have this groin pain, which can indicate potentially like a ureteral stones. So the pain radiates to maybe the testicle or labia. Already kind of went into detail about subjective data when it comes to abdominal pain. Additionally, individuals may come in with some dyspepsia. Dyspepsia is going to be indigestion, nausea, vomiting, dysphagia, that's difficulty swallowing, and then odonophagia, that is painful swallowing. They may have epigastric pain, again, remembering your different quadrants and regions. Hiccups, rectal pain or fullness, a change in their appetite. Another concerning subjective data that we may obtain from somebody is that they're vomiting up blood or they're having bright red blood that they are vomiting up, which could indicate an esophageal irritation. So an ulcer of like the stomach or duodenum potentially, and that technical term is hematoemesis. And then you have pyrosis, which is heartburn, and that can be an acute or chronic gastric disorder or concern that could be causing this. Do not confuse this with flatulence, belching, bloating, or nausea. Those are all different things than pyrosis. And then typically it's caused or aggravated by stress, spicy foods, caffeinated beverages, alcohol, meds, nausea, vomiting, and pregnancy. So, what are some common urinary elimination problems someone may come in with? So, first, they may have some urinary retention. That's that inability to completely empty the bladder. There's many different reasons for this. Maybe there's an obstruction, a neurological deficit. Maybe they're post-op and they've had anesthesia. Certain medications can cause this as well. Then UTIs, which we talked in a previous week in more detail about. That's an infection of the bladder, urethra, or kidneys. They may have some dysuria, frequency or urgency, maybe some suprapubic pain. Their urine may be cloudy or foul smelling. And then in your older adults, sometimes they will have confusion and delirium are their only symptoms. And then you have urinary incontinence. So this is the involuntary loss of urine. There's several different types. You have stress incontinence, that's leakage when coughing, laughing, or with activity. You have urge incontinence, that's when you have a sudden strong urge or like a quote unquote overactive bladder. You have mixed, that's any one of the different types of urinary incontinence, but primarily you'll see that a mixture of stress and urge would be your mixed. Overflow incontinence, that is when there's dribbling that occurs due to retention or possibly an obstruction. You have functional, it's just when someone cannot reach the toilet due to maybe a mobility or an environmental barrier. And then you have reflux, that's a more of a neurological concern that they have no sensation when they need to void. You also have some other terminology that you will hear in correlation with urinary elimination, either concerns or when you're asking questions during your subjective data collection. So you have nocturia, that is when someone is going to wake up at night to urinate. That can become a little bit more common as somebody ages. You have polyuria, so that's an excess urine output. So that's typically greater than about 2.5 to 3 liters in a day, possibly due to an increase in fluid intake, diuretics, diabetes insipidus, maybe caffeine and alcohol intake. Then you have the opposite, which is olguria. That is a decrease in urine output. So typically less than 400 mLs in a 24-hour period. Some things that cause this: dehydration, maybe acute kidney injury. Are they shock or hypovolemia, which is a decrease in fluid volume, and possibly even an obstruction in that. You also have anuria, so that's when no urine is produced or less than 1,000 mLs in a 24-hour period. Typically, this is with somebody that has a complete obstruction, like a stone or tumor, or they have severe renal failure, and potentially even your shock patients as well in the ICU. You have hematuria, so that is blood in the urine, trauma, kidney stones, a UTI, even sometimes menstruation contamination. You can see blood in the urine, and then even if somebody does have cancer, you may see hematuria. You have dysuria, that's painful or difficult with urination. Again, causing this could be a UTI, urethritis, so inflammation in the urethra, any type of vaginal or bladder infection or irritation. You have urinary frequency and urgency, and then you also have enuresis, and that is going to be, that's that last one on this list. That is involuntary nighttime urination in children. Typically, as they age, it will become more controlled and this won't occur. Typically, what will cause this is maybe bladder immaturity, stress, genetics. If they're a deep, heavy sleeper, this could occur as well. So then when assessing the urine itself, we want to look at the color, clarity, odor, the amount, the frequency, and then we do check lab values as well. This is all going to help us cue into the individual's hydration status, if there's an infection, what their kidney function's like, if there's any type of metabolic disorders. So first, we'll look at the color. So typically we want to see pale yellow to maybe an amber color, but typically it's going to be a pale or a transparent yellow. If you have somebody with dark yellow urine, possible dehydration. If they are clear or colorless, they maybe are on a diuretic or they're pretty hydrated, maybe to the point of overhydration. If you have any red or pink, that is hematuria, so there's blood. Certain foods can cause this color change. Same with if someone has a UTI, maybe some stones. Brown or tea colored, we're thinking like a liver disease, maybe myoglobin. So we need to start thinking about what else is going on with this patient and dehydration. Orange, there's a specific medication called pyridium that is actually going to turn their urine like a neon, pretty bright orange. And then more not so neon orange could indicate dehydration as well. For some reason, if you see blue or green urination, that may be due to a medication, maybe dyes that they have consumed in like their food or their drinks. And then also a Pseudomonas infection can turn that urine that blue-green color. Clarity, we're looking at that appearance. Is it clear or cloudy? Typical within normal limits, within defined limits, we want to see clear or maybe slightly cloudy. If you have an overly cloudy urine sample, it's indicative of infection, maybe some protein in their urine, some crystals, so there's something else going on. A milky color is called pyuria, and that is like a pus like drainage within that urine. And then if it's really foamy, that can actually indicate proteinuria, so protein in that urine, and maybe they have a possible kidney concern or kidney disease. The odor, typically we want it to be like malodorous, no odor to it. Depending on certain disease processes, you can have different smelling urine. So an ammonia-like urine, that's if something is left standing or maybe dehydration. If you have a sweet or fruity, we're typically thinking diabetes, maybe high sugar levels. Foul or strong, there's some type of infection. Do we have a UTI going on? And then, as always, certain medications and food may change that smell even of your urine. Then your amount. So you have, like I said earlier, you have, normal output should be 30 mLs an hour, or that equals to about 800 to 2,000 mLs a day, depending on their intake. But normal at minimum is about 30 mLs an hour. Low, which is alguria, is less than the 400. Anuria is less than 100 mLs a day. And then high, which is polyuria, is greater than that 2.5 to 3 liters in a day. Frequency can also be something that we need to assess when we're assessing the urine, is asking them how much they go. Typical is going to be every 3 to 4 hours. It's going to obviously vary on intake. If they have increased in frequency that they are going to the restroom to urinate, that potentially could indicate maybe are they pregnant? Do they have a UTI? Maybe diabetes or some type of irritant is occurring. If they have an urgency, like a sudden urgency and need to go to the restroom, is there an infection? Do they have an overactive bladder? So many different things can go into that assessment of urine and output. So then what are some common bowel elimination concerns? So first we have constipation. That's that infrequent or difficulty passing of like these hard, drier stools. So if someone has a low fiber diet, if they're not intaking enough fluids, certain medications can also cause constipation. Fecal impaction, that's when there's a hardening of the stool is lodged in the rectum and then cannot be expelled. So this is typically due to an untreated or severe case of constipation, opioid use, that's going to slow everything down, leading to potential fecal impaction. If someone is dehydrated, maybe they have a disability or a cognitive impairment, that can lead to, you'll see that more frequently with fecal impaction. Then you have diarrhea. We all know what diarrhea is. Incontinence, you can have fecal incontinence as well. That's that involuntary loss of stool or inability to control defecation. That could be due to maybe some neurological impairments. Do they have a stroke? Do they have MS or dementia? Um, Even if they have severe diarrhea, that can lead to incontinence. Sometimes impaction can lead to this as well because it's that overflow around the impaction that can cause a diarrhea and then incontinence. Then you have flatulence, that is going to be gas. So that's accumulation of gas within the intestines, causing maybe a discomfort or distension, and then the passing of that gas. And then you have potentially hemorrhoids. That is when you have like these dilated, swollen veins in the rectum or the anus. Will typically is caused by pregnancy. If you have chronic constipation and you're really straining to void, that can occur. Prolonged sitting, someone has a low fiber intake, those are all things that can lead to hemorrhoids. Then you have hematochezia, that is bright red blood in the stool. Typically, if you have bright red blood, that's going to be more due to colon cancer, hemorrhoids. Is there any anal fissures occurring? Diverticulosis, inflammatory bowel disease. And then you have melena, that is black, tarry, sometimes foul smelling stool. That is from more digested blood. So this, we're thinking if someone has melena, that it's an upper GI bleed. So looking at peptic ulcer disease, esophageal varices, do they consume gastric mucosal irritation medications or food or drinks such as NSAIDs, alcohol, caffeine? All those are irritants that can cause potential bleeding in that upper GI. When assessing the stool, we do want to look at the color, consistency, the amount, frequency, what's that shape, which we have the Bristol stool chart off to the right-hand side on this slide, and then the presence of any abnormal substance within the stool. So the color, typically we're going to see a brown, that is normal, and that's due to that bilirubin breakdown in the GI tract and being excreted out of the body. If somebody has clay or like a gray color stool, that may indicate a lack of bile. So is there a possible biliary obstruction or liver disease? Black tarry and red. Again, we talked about those already in regards to, is there a GI bleed upper or lower? Green stool is typically because there's a rapid transit from oral intake to excretion. Sometimes infections, or just simply ingesting certain green foods or dyes. Like I know my kiddos love these Grinch cookies my mother-in-law makes, and they're green cookies. Well, that typically is going to turn their stool like a pretty neon green color because of the dye. You have yellow, pale, or greasy appearing stools. That's called staturia. That's when there is fat malabsorption. You'll typically see that, and that's something we want to watch for, especially with our individuals that have pancreatitis or celiac disease. Consistency, of course, we do want to follow that stool chart. Your normal or within defined limits is going to be reformed and soft. Looking at the shape, uh, sometimes if you have like a ribbon-like or pencil-thin shaped stool, that can indicate a possible obstruction or tumor or something that's causing the significant narrowing in that GI tract that's making that stool look or appear thin. And then small pellet-like, that can usually indicate possibly slow motility or dehydration. We also want to look at their frequency and assess it against their baseline. So normal is really going to vary from 3 times a day to maybe 3 times a week. So it's really going to be dependent on what that person's baseline is. If someone is typically going 2 to 3 times a day and all of a sudden now they have not had a bowel movement in 2 weeks, well, that's concerning. But if you have someone maybe who only has one bowel movement a week and it's been 2 weeks, that's not as concerning as someone who goes more frequently. You do need to take into consideration the odor. Typically, it's going to smell not so great. But if it's really pungent and foul, there's certain disease processes that can cause this. So if there's malabsorption occurring, maybe a GI bleed is going to make it smell extra foul. And then you have an infection called C. diff, which once you smell C. diff, you are always going to be able to identify it as a very specific smell. If you have like a sweet or sour smelling stool, there may be some type of like carbohydrate malabsorption. So think of those who are lactose intolerant. Their stools may have a more sweet, sour smell. And then any abnormal contents. So that's those constituents. That is, blood, mucus, pus, undigested food, parasites or eggs that can occur in individual stools. That's going to be an infection, something's going on. Fat or oily residue, again, that's going to be your statorrhea. If you see any pus or drainage, that's going to be an infection. Undigested food, that maybe that individual has poor digestion, or there is a rapid transit from intake to exit. And then same with mucus, that's we're concerned of an infection. Is there an inflammation occurring like IBS or IBD? And then we always want to make sure that we are looking at associated symptoms when we're assessing that stool. So when we're assessing the stool, do they also have cramping and abdominal pain, nausea, vomiting, bloating? Is there a fever present? Have they had weight loss or weight gain? And that's going to help us really see that full picture of the patient. And then, of course, you have factors that are going to affect elimination as a whole. So you have your growth and development. Your infants and toddlers and your elderly are going to have changes that are going to affect that elimination. So infants, they're going to have immature neuromuscular control. That's why they have frequent stools. That's why they don't have the ability to control their bowels or their bladder. Toddlers, that's typically when we're going to start getting into that toilet training age. So that's when they're going to start to come aware of those voluntary control and that we can hold on to our urine and our stool until we get to a bathroom. Older adults, on the other hand, they're going to have a decrease in peristalsis, so in that movement. Decrease in their thirst sensation. They're going to have potential weakening of those pelvic floor muscles. That can lead to multiple different things like constipation, urinary retention, nocturia, increased incontinence risk. So age does play a factor. You have socio-cultural factors as well. So what does somebody assume is their privacy expectations with their ability to eliminate? So some people are just very uncomfortable going to the bathroom in public places. So are they holding their urine or their stool because of this? Are there any cultural practices around toileting or hygiene? And then work schedules or limited bathroom access can lead to delayed elimination and constipation. Your nurses are one of your first ones that are going to tell you that they are holding their bladder for a good 12-hour shift. There was plenty of times that I would get through a whole shift and I realized I had not used the bathroom since the start of my shift. And that is going to be that delayed elimination. And so, depending on their profession, and if it's causing issues, do we need to get them? What do we need to do for them? What education can we provide? And we'll go into that later. Psychological factors, stress and anxiety can actually increase the peristalsis in the movement, leading to diarrhea or even potentially retention due to muscle tension if there's tension. Depression, emotional depression can cause peristalsis to slow down, leading to constipation. Personal habits, it just depends on if they're bathroom shy. Again, like I said, do they want to go out and utilize their restroom either to void or defecate while they're out in a public place? Fluid and food intake. So hydration is a huge key factor here. So if they're having adequate fluid intake, they should have a fairly normal urine output. But if they have low intake of fluid, specifically water, that's going to cause them to become more dehydrated. So their urine is going to become concentrated, maybe decrease in that urine output. And then for their bowels, they are going to have an increased risk of constipation. So with that, diet can also cause issues. So high fiber can actually increase stool bulk and improve motility. So that is great if for somebody who is constipated. But if they're getting low fiber, that's going to actually cause constipation. If someone's consuming spicy and greasy foods, that likely could cause potentially diarrhea. And caffeine or alcohol intake can actually increase urine output because it does play that diuretic effect. There's also pathological conditions. So, thinking of any neurological disorders, stroke, spinal cord injury, MS, those individuals may have a loss of control. They may have retention concerns or incontinence concerns. Your diabetic individuals, may have that polyuria or even some neuropathy affecting the bladder tone, leading to incontinence. If they have any type of mobility impairment, we do want to make sure that we are discussing accessing the toilet and how can they get there and how can we help with that movement. GI diseases, so IBD, IBS, is there an obstruction infection? Those are all things that can cause either diarrhea or constipation. And then position, as simple as position. A sitting or a squatting position is going to facilitate a normal defecation. That's why toilets are the way that they are. If someone is laying in bed and they are trying to go on a bedpan, sit them up. That's going to help the normal defecation process. If they're lying flat, it is going to be a lot harder for them to pass the stool. Pain can affect this. So if they're having pain with defecation, maybe they have some fissures or hemorrhoids, they may just be holding on and not wanting to go to the bathroom. So that could lead to constipation. Also, after somebody has a procedure, they may be on some medications or they're having pain elsewhere and they're on opioids. That's going to decrease motility and lead to more retention. Pregnancy can cause changes as well. During pregnancy, you have an increase in progesterone, and that's going to slow the motility, leading to constipation. And that's why a lot of times they will have somebody on a stool softener. And then again, surgery and anesthesia, it's slowing everything down, so it can lead to constipation, urinary retention. And then medications. You've got if somebody is constipated, are they on an opioid? Are they taking iron? Are they on an anticholinergic or a calcium supplement? If they're having diarrhea, well, were they on an antibiotic? If they're on an antibiotic, certain antibiotics can increase their risk of C. diff. Certain magnesium supplements and metformin. Metformin is going to be one of your type 2 diabetic medications. That's very common to cause diarrhea. And then altered urine color, again, pyridium could change that color. Same with rifampin can change the color of your urine. And then diuretics may lead to an increase in that urine output. So many factors can play here. Diagnostic testing, if they have a bowel prep for a colonoscopy, well, they're going to be going to the bathroom really frequently because the bowel prep is helping clear those intestines. And certain contrast dyes that can actually change the color of someone's stool, and it may even stress the kidneys, leading to concerns with urination. So then there's past medical history, family history, and lifestyle considerations as well. Do they have recurrent GI or GU concerns? Are there adhesions that are leading to any of these elimination concerns as well? Certain medications, aspirin, ibuprofen, and steroids can all cause bleeding within the stomach. Antacids and histamine blockers can prevent serious stomach problems from occurring. So are they taking that? Do they have an allergy to it? Iron, typically, if somebody is on iron, it can actually cause constipation. So making sure that we do assess, are you on an iron supplement? Did you get one over the counter? Laxative abuse and the high utilization of a laxative can actually decrease intestinal tone. Family history, any type of cancers, colon, stomach, liver, pancreas. Are there any type of cancers like that in your family? Does your family have a strong history of kidney or gallbladder concerns? Lifestyle wise, assessing alcohol consumption, checking that nutrition and fluid intake. What about their caffeine consumption? We kind of talked about this on a previous slide. What's their exercise regimen look like, especially if they're having any type of retention, either urinary or bowel, getting them up and moving if possible. Smoking, stress, and also just body image concerns. When it comes to elimination, there's many things that can actually lead to someone having some negative body image thoughts. So we want to assess that. So then we have some diagnostic tests, some screenings, and some procedures for the abdomen and GIGU. So laboratory test, we will typically do like a CBC, a CMP, BMP. Those are your pretty standardized overall labs. You have liver function tests, so we're going to be checking those. That includes an AST, ALT, ALP, and bilirubin. That's going to be checking, of course, the liver and to see if there's any active liver disease. You may be checking lipase or amylase. That is going to check for pancreatitis. A CRP or ESR, that's going to look for inflammation. And then, of course, you're going to do a urine testing. So you've got a urinalysis, so that is collecting to test that urine, a clean catch, sterile and timed. So making sure you do know the difference between those. Clean catches when you're going to have to provide education on making sure that they use the 3 wipes to clean around that urethra, around that area to provide a clean catch urine to test for possibly a UTI. Sterile is typically going to be coming from like a urinary Foley bag. And then timed, that may be a 24-hour urine. So obtaining urine from a specific start to a specific end time, and then collecting that urine for a 24-hour period. In addition, there's also some stool studies that can occur. And so we can obtain like an occult blood, an ova and parasites. We can do a C. diff toxin, do a culture, test for fat, which would be statorrhea. And then you have the images. So we can do an x-ray, which would be like a KUB, kidney, urine, or bladder, or an abdominal x-ray. That's going to detect any type of obstruction, perforation. Is there constipation or calcified stones present? You can do an ultrasound. You can do a CT with or without contrast. You can do an MRI. That's going to be typically to look at further at liver lesions, if there's any soft tissue abnormalities, if there's any issues with the biliary or pancreatic ducts. And then you do have certain endoscopic procedures. You have a G or an EGD, esophagogastroduodenoscopy. Rarely do I say the full name. Typically, I've always said just an EGD. That's going to visualize the esophagus, the stomach, and the duodenum. We're going to do that to look for ulcers. If there's bleeding, to diagnose why there's bleeding occurring, esophagitis, and strictures. And then maybe even biopsying for like H. pylori or Barrett's esophagus. And then you do colonoscopies. That's going to be your colon cancer screening. It's going to detect for any polyps, diverticulosis, or inflammation. You can biopsy or remove any polyps present. You have your sigmoidoscopy that is going to visualize the rectum and the sigmoid colon, and that's just a screening alternative to your colonoscopy. And then you have your cystoscopy, and that is going to be for your urine. All right, now we get into our objective data collection. So with this, the cardinal techniques for an abdominal assessment are going to be different than the other systems. You want to do inspection, you want to auscultate, you want to percuss, and then you want to palpate. So why do we not auscultate last like we do in most of the other systems? So you would want to do this last because if you palpate and percuss that area in the abdomen, it's actually going to stimulate peristalsis. So tapping or touching the abdomen is going to increase that bowel activity. And so then that may lead to false interpretation of maybe hyperactive or normal bowel sounds. If someone typically it has a hypoactive bowel sound, but we go in, we palpate, we percuss on that abdomen, and then we listen, well, it could sound normal, but we are falsifying that because we have now manipulated the bowels. So that is why you always want to get a baseline unstimulated bowel sound first. And as always, we always inspect and then we palpate, then we move into like palpation, percussion, auscultation. With this though, we'll do inspect, we'll look at that abdomen, listen, percuss, and then palpate. So first we have inspection. So abdominal inspection. So how do we as nurses position our clients for an abdominal assessment? So you actually want your patient to be completely supine. So the head of bed needs to be flat. And then you will be inspecting. And if you do any type of visualizations of any movements, you do want to be at eye level. You will have their hands next to their side of their body. You don't want them like trying to cover up their abdomen. And sometimes that can even be an indication if they're covering up their abdomen or they having like guarding or pain and what that could lead to. So first we want to look at the color. So the color typically is going to be paler than the rest of the body, but it should still be consistent with their ethnicity. You know, is there any jaundice, like extreme pallor or cyanosis? Checking for lesions, rashes, striae, ecchymosis. Ecchymosis, you may see there's two different quote unquote signs. So you may see what we call gray Turner. That's going to be that top image where they're having this like flank bruising. So this is going to be the bruising on the side of your body between like your ribs and your hip, which is what we call the flank area. This may happen if you have a bleed in like the back of your stomach. And it can also be seen with like acute pancreatitis. Then you have colon signs. So that's where you have this ecchymosis or bruising, but it's around your belly button. And that's that bottom image. It's right below that belly button. Again, these are indications of acute pancreatitis or some type of bleed that is occurring in the abdomen. You also want to look for vascularities. Um, Typically, you may see some scattered fine veins in their abdomen, but abnormal would be those dilated veins, then we are concerned. Again, you may see striae, cicatrix, lesions or rashes. And then as always, when we're doing a skin assessment, looking for any changing of like moles or spots. And then you typically will see a midline umbilicus. Now with that, underneath here, it says also your colon sign. So if there is a GI bleed or something occurring, that you may see this bruising in their abdomen, which is the colon sign, but they may also have an umbilicus that's not midline because of where that bleed is occurring. You also want to assess, and this is where you have to do it at the same height as that patient. So you would, crouch down and visualize their abdominal contour. So is it flat? Is it scaphoid? Scaphoid's going to be more sunken in. You have rounded. And then you have protrudent. And you can see that in the image on the difference between them. So why would there be abdominal distension where they are maybe rounded or protrudent? You know, that's your F's. So your 6 F's. So fat, feces, flatus, fibroids, fetus, and fluid. And then also you want to be looking for any peristaltic waves or movement. This is not something that is typically visualized. You may see some or slight movement or rippling in a very thin client, but it is abnormal if you see like a pretty visualized wave from that left upper quadrant to the right upper quadrant. That means that there may be a potential intestinal obstruction. So then after we do our inspection, we're going to auscultate. So we're going to listen. Again, this needs to be done before we percuss or palpate to avoid stimulating bowels and increasing that motility. With this, we want to utilize the diaphragm of the stethoscope for any bowel sounds, and then we will utilize the bell for any vascular sounds. So, what are we listening for? So, normal bowel sounds are going to be these high-pitched, gurgling, intermittent noises. They're going to occur about every 5 to 15 seconds, and that's just caused by movement of air and fluid through the intestines. Hyperactive bowel sounds, that is going to be loud, high-pitched, rushing, and frequent. And this we are thinking diarrhea. Maybe they have some diarrhea, maybe an early obstruction, gastroenteritis, maybe some laxative use that's causing those hyperbowels. Then you have hypoactive bowel movements. This is going to be more soft, slow, infrequent sounds. Causing this maybe a later obstruction, post-op abdominal surgery, narcotic use or opioid use can slow the bowels down. With that, though, we want to also note if there is any absent bowel sounds. So, if there are no bowel sounds, you're not hearing anything when you're listening in each quadrant, then you will need to listen for a full 5 minutes. So let's back up. So how do I auscultate? We talked about doing the diaphragm. And you want to place your diaphragm on the stomach very lightly. If you press too hard, one, that's going to cause increased motility in the GI tract, and two, you're not going to be able to hear as well. You want to listen in each quadrant, so starting at that right lower quadrant, then moving clockwise. So right lower, right upper, left lower. And you want to listen in each quadrant for 15 seconds. So if you do that, you listen 15 seconds in each quadrant, that is 1 full minute. And if you hear no bowel sounds, then you will go back starting in that right lower quadrant and listen for a full minute. Then you will go to the right upper for 1 full minute, left upper for a full minute, and then left lower for a full minute. That would be a total of a 5-minute auscultation for bowel sounds. At that time is when you can put absent bowel sounds and notifying the provider as well. This can indicate maybe an obstruction. Is there abdominal cramping? These are things that are very concerning, and that's why we need to notify that provider right away. Again, like I said, that technique, making sure that you do start in that right lower quadrant, we are following that GI tract, and that is why we start there. So then we have other sounds that we're going to listen to. So with this, you have your vascular sounds. You've got bruits. With a bruit, this is going to be turbulent blood flow. What's that indicate if we hear this turbulent blood flow? Is there a possible obstruction? So you will auscultate, and in the image, they are the blue regions. You're going to auscultate at the aorta, the renal, and the iliac arteries. And because you're listening vascularly, you want to utilize that bell. Then you have your friction rub. Your friction rubs, these are going to be high-pitched, rough grating sounds. And this is going to be over the liver and the spleen. And so with this rubbing, grating sound, it's indicating that there is possible enlargement of that organ. This is not a vascular sound, so that is why we're going to utilize the diaphragm. And where we listen for friction rubs are indicated in like the red or orange region of this picture. Then you have venous hums. We're back to a venous issue. So this is when we're going to utilize the bell. This is going to be like a continuous roaring or like a whining noise. And if you do hear a venous hum, it's going to indicate that there is potentially a portal venous hypertension or maybe some cirrhosis. So you will auscultate in the purple regions. So that is your epigastric and your umbilical region. And then now we are jumping to percussion. So we've inspected, we've auscultated, now we will percuss. We will not palpate until the very end. So what's percussion going to do? It's going to help us assess if there's gas, fluid in any organs, what the organ size maybe, and any possible masses or tumors that are, occurring in the GI area. So first, we want to make sure that we do a general assessment or percussion of the entire abdomen. So we want to do at least 3 spots in each quadrant. So the image on here is actually going to be wrong because it has you starting in the right upper quadrant. You will actually start in the right lower quadrant, just like you do for auscultation. So this image is wrong. It's a good image to show that in each quadrant, you want to percuss in 3 different spots, but we want to start in that right lower quadrant, move to the right upper, left lower. You'll do an entire abdomen percussion, and that is we want to hear generalized tympany. That is air-filled areas. If you think of like our GI tract, our large and small intestines, those are primarily air-filled unless there is, like stool going through them. If you hear something that sounds more dull in tone, that means that you're over a solid or fluid-filled area. So again, if you hear any dullness when you are percussing, there may be stool in that GI tract, depending on where you're percussing at. You will also do your liver span, and when you test over your liver when you do percuss, it's going to sound very dull because it is more of a, think of what type of organ it is. It's not going to fluctuate depending on its contents. Same with your spleen, you'll hear this dullness. And the images below do indicate that. I will attach a video as well in Canvas to help with visualization of performing a liver span, splenic enlargement test, and blunt percussion. Blunt percussion is going to be over the liver and the kidneys. Typically, we're going to see it more commonly done over the kidneys. Another term for this, or blunt percussion of the kidneys, is called costovertebral angle, or CVA tenderness. So what we will do is we'll hold our hand over like the 11th and 12th intercostal space, just like in that image, and then utilize our right hand and do a blunt percussion, and we'll hit hard on our palm. We're not hitting directly on the patient. So with generalized palpation, the client should be relaxed. So we want to make sure that they're relaxing those muscles, and then we will palpate over the area. We will do it in the exact same area when we're doing a light palpation that we did for our percussion. So we will do 3 areas per quadrant. So this we're going to assess for any tenderness and guarding. We want to only utilize 2 fingers and utilize our finger pads, go in 1 centimeter deep. And like I said, in 3 areas per quadrant, you'll begin at that right lower quadrant. If for some reason that right lower quadrant is causing them pain, then you will do that one last, because we want to do non-tender first and do whatever is tender at the very end, even if that is out of order for palpation. That is your exemption. So then we will move to a deep palpation. So we perform light palpation. We ask about pain or tenderness. We note if there's any guarding. Then we'll do deep. Deep is where you will utilize both hands. You'll do a dipping motion. You only have to do 1 per quadrant, and you go about 5 to 6 centimeters deep. At this time, we're going to be palpating for any masses or enlarged organs. Then when you do a liver palpation, so typically it's going to be non-palpable. If it is, it's like felt as like this smooth, firm edge. You may feel it for like a hot second. It's usually not something that you can like hold on to. An enlarged liver, so one that we can maybe feel or it's pretty palpable, that is called hematomegaly, so potentially caused by hepatitis, congestive heart failure, cirrhosis. If it is tender, so when you're palpating and that liver is tender or painful, There may be some inflammation going on or some congestion, leading to potentially hepatitis. So with this, you want to have them lie in a supine position. You will stand at the client's right side. You will put your left hand under their back at about their 11th or 12th rib. You'll utilize your right hand, place that at the right subcostal angle, and then and right midclavicular line. You'll have them take a deep breath in. At that time, you will compress inward and up with your fingers. Then you'll have them exhale, and that is sometimes when you can, like, quote unquote, catch that liver. Then you have what we call Murphy's sign. This is when we're going to test for cholecystitis. You will do the same technique as you did for a liver palpation, but you'll do it and you'll ask if they have any pain or tenderness. If they have pain or tenderness, that is a positive Murphy's sign. So what does an enlarged liver indicate? We kind of went over those several things that it could be. It could also be potentially maybe there's a tumor or even parasites. Infection, especially if there's tenderness, liver disease such as hepatitis, cancer, and congestive heart failure. It can lead to liver inflammation. So then we do our spleen. So we palpate that spleen. Again, we have them lying supine. We will stand on the left side of them, just because that is where your spleen is. You'll place your right hand under the posterior lower ribs, and then you'll have the patient take a deep breath in. You will then utilize your other hand. So your left hand, you'll compress inward and up with the fingers pointed toward the client's head, and you'll see if you can palpate that spleen. An enlarged spleen may indicate maybe mononucleosis or mono. Is there a trauma to that spleen? Some chronic blood disorders may enlarge the spleen, and some cancers as well. Then you have kidney palpation. With this, we'll palpate the kidneys. This is a bimanual technique. So you'll have the client laying flat. You'll support the flank with the opposite hand of the side that you're on. And then your other hand will be placed below that costal margin at the midclavicular line. You'll have the patient inhale. And then while they inhale, you will press deeply inward. And then you'll have them slowly exhale. This is when you may feel that kidney slip. Again, this is not common that you would feel this. A kidney may be enlarged because of, is there a cyst, a tumor, hydronephrosis. So we talked about cholecystitis. Now we have appendicitis. So what is appendicitis? This is when there is an obstruction in the appendix, and your appendix is located in that right lower quadrant. It's attached to the cecum, and it's found near what we call a McBurney's point. So if you draw a line from the right anterior superior iliac spine, or they'll like abbreviate it as ASIS, assist, to the umbilicus, McBurney's point is about 1/3 of the way up from that ASIS point. So with that, they may have pain located there. So there's several tests that we can perform to check for appendicitis. So you have your psoas sign. You'll have your client laying supine and then roll over to their left side. You will hyperextend their right leg. So remember what hyperextension is. If they have pain in specifically that right lower quadrant, that is a positive psoas sign. What is essentially happening is that iliopsoas muscle is being irritated because of that appendicitis, and that causes that pain when you hyperextend. Then you have obturator sign. You have the client now go back on their back, lay supine. You will support the client's right knee and ankle. Then you will flex their hip and internally and externally rotate that hip. If, again, they have pain specifically in that right lower quadrant, it is a positive obturator sign. And why that occurs is because that obturator muscle that we are moving is irritated from that appendicitis. Then you have Rovsing sign. So this one is where you will palpate that left lower quadrant, and they'll actually have pain in their right lower quadrant. So that would be a positive sign. Bloomberg is where you will palpate down that left lower quadrant and then immediately release, and you'll be assessing for pain upon release. If they have pain on release in that right lower quadrant, it is a positive sign for appendicitis. So now let's look at elimination health promotion that we can provide for our patients. So again, elimination refers to that removal of waste products via urinary or bowel systems. So we want to help promote healthy elimination and prevent any complications, as that's a key aspect of us as nurses. So primary prevention. So the goal with that is to prevent problems before they occur. So with urinary elimination, we want to make sure that an individual is getting adequate hydration, encouraging 6 to 8 glasses of water daily to really maintain that adequate urine output and prevent UTIs or kidney stones. Hygiene, educating on proper perineal care to reduce infection risks. Also with toileting habits, making sure that they are regularly voiding and avoiding holding their urine for a prolonged period of times. So again, think of our females making sure that they are not wiping back to front, but rather front to back. Lifestyle changes, making sure they, maintain a healthy weight, avoid smoking, limit any bladder irritants. Bladder irritants and bowel irritants include caffeine, alcohol. For bowel, it's your spicy foods, watching their diet. So making sure that they get enough fiber and fluids. That's going to help prevent any constipation. Dietary fiber, that's going to include fruits, veggies, whole grains. Hydration, again, that's going to help with not only urinary elimination, but bowel elimination as well. Physical activity, making sure that your individuals are getting up and moving. If they are in the hospital, that we're getting them ambulated as much as possible, getting them up to the chair. That's just going to help promote that peristalsis and regular bowel movements. Some secondary prevention, that is going to be your early detection and prompt intervention to prevent any complications. So doing screening for UTIs, especially in our older individuals or individuals that have catheters, that are maybe diabetic or have reoccurring infections. You can also do an assessment, which is called a post-void residual, if I can speak today. That is where we are going to detect any urinary retention. So we have them void, and then we do like a bladder scan to see how much urine is still left in the bladder. Obviously, we're going to monitor for any incontinence. Early evaluation of this and intervention is going to help prevent any infections, but also prevent skin breakdown, social isolation, and falls. So we're looking a lot more holistically at the patient. We'll do some renal function tests to detect any chronic kidney disease, especially in the early stages. In regards to bowel elimination, we do want to educate on those colorectal cancer screening, also your prostate screening, and if need be, having an individual do a colonoscopy. So then what are some elimination interventions or maybe medications that we can utilize? So there is catheterization or urinary catheterization. That's going to relieve any urinary retention. It's going to help us more accurately measure output. It may manage incontinence if that individual is having incontinence or assist with certain procedures. So you've got your indwelling, which is a Foley catheter. You have intermittent catheters, which are your straight catheters, such as temporary drainage. You have a suprapubic catheter. That's going to be a surgically placed catheter for long-term use. Ultimately, though, we don't want to have to utilize a catheter, but if we do, as a nurse, we need to make sure that we are doing appropriate aseptic techniques to prevent UTI when caring for that catheter. We want to make sure that we're monitoring urine output and characteristics. We're making sure that that device is secured appropriately and there's no obstruction in the drain and the tubing down to the bag, because that can lead to, if there's a kink, the urinary urinary retention and backflow, which is just a huge risk for infection, and it's uncomfortable for the patient. Making sure that we provide perineal hygiene and care, but also educating our patients if they are on this long term and go home with it or need to do any self-catheterizations at home. We also want to always assess for catheter-associated complications, looking for and assessing bladder spasms, trauma, infection, any signs and symptoms of infection. Some medications for urinary elimination, you may have some like anticholinergics, your beta-3 adrenergic agonist, sometimes antibiotics depending on if they're diagnosed with a UTI. And then you can also be on like these, what we call spasmodics, and that's going to help relieve any type of urinary spasms. For bowel elimination medications, you may have your different laxatives that someone's on, an antidiarrheal, your certain medications to help prevent constipation. And so knowing those general bowel elimination medications are going to help you when educating your patients as well. On top of that, you also have enemas. So this is what you will give when somebody has constipation, or maybe we need to cleanse their bowels before a procedure, or just help stimulate that defecation process. So we always want to administer an enema when the patient is left side lying Sims position where their knee is flexed up. So the image similar to here on the slide. With this, we want to encourage the patient for most enemas to retain the solution as long as they can. Hold it in, that's going to help. We do want to monitor though while they are getting this enema and even after for cramping, discomfort, or if there's any rectal bleeding that does occur. And then simply positioning of the client to void. We talked about this earlier. If someone is on a bedpan, let's get them seated up on that bedpan opposed to lying flat. That's going to help promote elimination. There's also something called digital removal of stool. So this is going to be done with severe fecal impaction. This is when you'll utilize a lubricated gloved finger to gently break up the stool in your client's rectum. This is something though that is a last resort, not something that we do commonly. Why? Because we need to closely monitor their vitals, because while we are removing that stool or that fecal impaction, we can actually cause the patient to vagal. So with that, a vagal response can occur, and that would drop their blood pressure and drop their heart rate. So again, that's a last resort intervention. And then you may end up needing or seeing somebody with an NG2. This is where we're going to decompress that stomach, remove contents from the stomach. We can administer medications or nutrition through there. With that, we as nurses can place that NG2, but we will need to confirm the placement with an x-ray. They also can do like pH or an aspirate testing before utilization, but standard is going to be an x-ray. When you do this, or while they have an NG place, we want to monitor for any discomfort, nasal irritation, aspiration. And then we always want to maintain patency in that NG so that it doesn't get blocked off, and we always want to secure that tubing appropriately. And we'll irrigate it per policy to keep that patent. So then we have urinary and bowel diversions. So these are surgical procedures that reroute the normal elimination pathway because maybe there's disease, there's injury, or there's some type of congenital concern. These can be either temporary or permanent. So with urinary diversions, typically that will occur if there's bladder cancer, neurogenic bladder, trauma to that urinary system, maybe in some congenital anomalies, or chronic infection or obstruction. So there's several different types of those, but the most commonly termed one is going to be your urostomy. With this, we always want to make sure that if someone does have a urostomy, that we're monitoring their urine output and hydration status. We're doing those strict I's and O's. We're looking at the color and clarity. We're assessing the stoma. So that stoma is the temporary or permanent artificial opening in the abdominal wall, whereas your ostomy is the actual surgical procedure in which an opening is made into the abdominal wall. So that's the two differences between that. The stoma, so we want to make sure that we are assessing that stoma. Is it pink, moist? We do not want to have any necrosis. We don't want it to be dry. We want to also help make sure that we are preventing infection and we're appropriately cleaning around that stoma when we're changing the bag. That goes just the same as if someone has an ileostomy or colostomy. So, bowel diversions. Why would we do a bowel diversion? Maybe that individual has colorectal cancer, severe diverticulitis, inflammatory bowel disease like Crohn's, ulcerative colitis. Maybe there's trauma or an obstruction occurring, and again, congenital anomalies. So you have several different types of these as well. So you have a colostomy. That is a part of the colon is brought to the abdominal wall as a stoma. The stool is typically going to be like a semi-formed, whereas your ileostomy, that is where your ileum is brought to the abdominal wall, and that output is typically like liquidy and it's high in electrolytes. So someone who has an ileostomy is at risk for dehydration. Again, nursing considerations, we want to assess the stoma color, the size, protrusion, monitor any output, the consistency and odor of that stool, and then making sure we provide appropriate skin care. So making sure that that area is not broke down when we take that bag off and put it back on. So if a diversion is completed, whether it's urinary or bowel, we want to always post pre-op before we perform it is to provide education. Marking the site of where that stoma is, letting them know all the educational components, what this is going to look like for them, discussing lifestyle changes, because this is going to be a huge new thing for them. It can cause body image issues, social adaptations, because now they have this bag. Post-operatively, we want to make sure that we monitor that stoma, making sure that it's still like pink and moist. It's not becoming necrotic. It's not having blood supply cut off to it. We want to assess the output, watch and look for infection, looking at that skin integrity. Long-term care, making sure that the patient knows how to apply the ostomy or the bag, their diet, hydration, any complications. This is just a good like visual aid of the different types of ostomy. So ones we just talked about, the colostomy, ileostomy, and urostomy, like the location, some memory tricks, and just kind of just some generalized things to make sure that you're aware of. So this is some information on the stoma and bag care that you guys can review. It's something that you guys will be doing or have done in lab. I also have attached an ostomy bag pouch change video so that you guys are aware of that. So just being educated on your different types of your ostomy versus your ileostomy versus your urostomy, that stoma care and how to do these bag changes is going to be important for you to be aware of. And then lastly, if you have any questions or concerns, please feel free to reach out to me.